Everyone. Thanks for joining us for another Academic Half Day. We have a great lineup of all resident speakers today and some really good talks. So we're going to start with Jennifer Dunlap's talk on syndrome of imminent death. And you are free to go, Jen.
All right. Hello, sea of Black faces on Zoom. For anybody who doesn't know me, I'm Jennifer. I'm a second-year resident, and I wanted to talk today about what we call the syndrome of imminent death, and a little bit more broadly, end-of-life care that we provide in the hospital. First and foremost, before we get started, I don't have any financial or other disclosures to report. There we go. And then the first thing I wanted to spend a little bit of time on is why I chose this topic, which is admittedly a little bit gloomy. And it's really no secret that we don't talk about death and dying much in the United States. And in residency, beyond getting some just-in-time training about family conferences and how to have a better code status conversation, I've not had a lot of dedicated teaching in this area. And so this came from a very personal place where I had some experiences in residency where a patient presented often for altered mental status, and things weren't quite adding up with their story and their vitals and their diagnostics, until I physically went to the bedside and either somebody who was there in the room with me or I myself was able to recognize that they are, what we often term actively dying. And so this talk came from my curiosity to understand this phenomenon that I was identifying but couldn't really name, and learn if there was a way to describe this and teach it to loved ones at the bedside and people, trainees, med students, and interns that I'm working with. So personally, that's where I'm coming from. In terms of why this is an important topic for providers, we have good evidence. Well, in the hospital, typically we're focusing on cure and life prolongation, and impending death is often recognized late. But we have pretty good evidence that physicians who are aware of impending death communicate better and more frequently with patients, with families, and provide more appropriate care and avoid unnecessary interruptions in interventions in the last day of patients' lives. Specifically with COVID restrictions, many patients don't get visitors unless they're at the very end of their lives. This is a particularly important thing to recognize these days. I am by no means an expert in this topic. I think that a lot of what we're going to be talking about will be familiar to you, but will hopefully help bring together some disparate ideas that maybe people have recognized, and consolidate knowledge that you may probably already have. But I don't think we're going to take the whole 45 minutes for this talk, so please feel free to put comments in the chat or unmute yourself to share a different perspective at any time. And just trying to move to the next slide, maybe. There we go. Okay, so our objectives for this talk. First, we will describe, sorry, I'm trying to remote access. There we go. We'll describe the findings that are key features of the syndrome of imminent death. Second, to isolate high-yield, non-invasive physical exam maneuvers to prioritize in these patients. And then third, to briefly touch on some of the interventions that we do or do not pursue in managing patient symptoms at the end of their life. All right. Maybe Lauren, can I have you advance the slide? Thank you.
Sorry, that was my bad when I advanced it before.
That's okay. No worries. So first I wanted to define what we call the syndrome of imminent death. This is something that has been described that virtually all dying patients go through a stereotypical pattern of signs and symptoms in the days leading up to death. And we often colloquially refer to this as actively dying or imminent death. There's a high degree of accuracy that when patients are diagnosed with imminent death, that death occurs within 14 days. Typically, the time course is less than 24 hours to 2 weeks, with a median survival of 2 days. That's kind of a wide range, which shows, in part that it's very difficult to to provide prognosis to patients, but also, some patients are coming to this with a diagnosis of advanced dementia or advanced cancer, and they've been ill for some time. Other patients will present after a catastrophic event, and they go through this same stereotypical pattern of signs and symptoms, but because they are nutritionally intact, or they're nutritionally, they have good nutrition and they don't have maybe evidence of infection, those types of patients will typically live closer to 2 weeks. And an example that's often given in the literature is like a patient who suffers a massive stroke that eventually does end their life. And as I already mentioned, prompt recognition of this syndrome can be key. It can help us to prepare loved ones in advance and provide them most appropriate treatment, and avoid unnecessary interventions for patients. And again, I will beat over the head the COVID thing, but it can often allow us enough time to get patients back home with their families if that's the desire, to spend the last few days of their life at home. All right, next, I just wanted to go through the different stages of the syndrome of imminent death. Certainly there's a diversity of patient presentations and personal experiences of death and dying, but this is a pretty commonly described phenomenon. So functional status being the most important prognostic factor. Early in this syndrome of imminent death, that's when we have a prognosis of 1 to 2 weeks, and patients will become more bedbound. Family members will notice that they're having dysphagia or decreasing their oral intake, having little interest or ability to eat. And then they will have cognitive changes that include increased time sleeping or delirium. And a lot of family members, especially family members who have not been educated to expect these changes, will bring patients to the hospital for ostensibly an altered mental status workup in this time frame. So that's often when we are seeing patients in the hospital. The middle stages is really just characterized by a further decline in mental status from being a little bit more sleepy and less interactive to obtundation, where patients are slow to arouse to stimulation and really only have brief periods of wakefulness. And then the latest stage purports a prognosis of the hours to days, and is characterized by vital signs changes, including fever that is usually attributed to aspiration pneumonia, altered breathing patterns, including periods of apnea or tachypnea, and irregular breathing that we'll discuss in detail. The death rattle, which is due to pooled oral secretions after patients lose their swallowing reflex, cool and mottled extremities, and eventually coma, and is followed pretty closely by death. Oh no, I think there we go. So all of this information about these signs that we can see in patients who are actively dying leads to the question of how much physical exam should we perform on our dying patients, and what aspects are the most helpful and provide the best prognostication. And it's pretty natural for a lot of clinicians to want to avoid imposing on a dying patient, but there are ways that we can be non-invasive and not distressing to patients, and still get some very good practical information for both prognosis and assessment and management of symptoms. And then a good physical exam also is important to the loved ones who have been at the bedside in the past in the hospital, and hopefully again in the future. And really that laying on of hands, coming into the room and showing time and attention to loved ones really conveys clinician engagement and non-abandonment to family members. I think there's often a sense that if we diagnose a patient with the dying process, that then maybe we will forget about them and not pay as close attention to them and not provide interventions that are indicated. And so an appropriate physical exam can ease those fears for loved ones. All right. So I wanted to go through the physical exam findings that are most commonly associated with impending death. And we can talk about the things that we do and do not do in each of the organ systems when evaluating dying patients. This is not going to be a comprehensive list by any means, but I just wanted to isolate the highest yield aspects. And you'll notice that a couple of the bullet points are in bold throughout the talk, and those are the findings that are typically associated with the latest stage of the dying process and associated with death within about 3 days. So first, there are often vital sign derangements that are seen, particularly variations in blood pressure, tachypnea, tachycardia, or inappropriate bradycardia can be seen, and then fever or hypothermia. In our general examination, we're paying attention, we're just observing patients, looking to see, are they interacting with their environment, or do they have decreased response to visual or verbal stimuli? Is their neck hyperextended, which is where patients have the classic finding of their head being tilted back while they're laying otherwise supine. Grunting of the vocal cords, typically on expiration, is indicative of an imminent death diagnosis. A malodor can suggest infection, uremia, hepatic failure, and then less for prognosis, but more for just assessing a patient's comfort in bed, because there is a lot of terminal restlessness that patients experience, and they can find themselves in like being particularly askew in bed. And sometimes we can make them more comfortable if we, go to the bedside and recognize that they are not looking comfortable. The next section is skin findings that can be associated with active dying. I don't think anybody will be surprised that peripheral cyanosis of the distal extremities or modeling of the skin more proximally, like over the knees, portends a poor prognosis. But there are other particular findings that I learned about in preparing this talk, including the Kennedy terminal ulcer that reflects skin failure as like the organ system failure of the skin. And so before I click to the next slide, I just want fair warning for anybody who's eating breakfast. The next slide has a lot of sacral ulcers. So just like, we'll get through it together, but maybe take a break from your breakfast. So these are not the highest quality photos, but they're the best I could find to show the stages of the Kennedy terminal ulcer, which is not a pressure ulcer, and we'll talk about that. So this is an ulcer that typically occurs on the sacrum. It can occur on other bony prominences like knees and elbows, and it is an indication of skin failure. It's typically described as pear or butterfly shaped with irregular borders, and it's pretty asymmetrical. And then I tried to organize these pictures in order of like progression, and you'll see that they typically start off looking like a bruise, and there's a range of colors, usually starting with like that purplish or red color that can become yellow, and then in the latest stages, black and swollen, which is obviously necrotic. So moving on. As I said, this is a sign of organ failure of the skin, and usually signals an imminent death within, these occur in the final 2 weeks of life. It's really important to communicate with loved ones that these wounds occur despite excellent wound care and preventative measures. And so you'll have family members who notice these wounds occurring at home and harbor a lot of guilt over not taking good enough care of their loved ones, or alternatively, if these crop up in the hospital, there can be feelings of mistrust or anger from loved ones that we're not providing, appropriate wound care. And so preparing loved ones that this is a different type of ulceration can go a long way. These wounds occur very suddenly and grow very rapidly. So that's how they're distinguished often from just a pure pressure wound that gets worse over the course of days. Typically, the bruising, will be first noticed in the morning, and it will be ulcerated and necrotic by the afternoon. It can happen over the course of a day or hours. The progression in the pictures I just showed you occurs. And, not surprisingly, these are irreversible wounds that are part of the dying process, and there's no specific evidence-based treatment for these. We don't understand exactly why they occur, except that, poor arterial perfusion and and just that the skin as an organ system is not being perfused and is dying. And so often we'll continue the typical wound repositioning and skin care that we would do to prevent pressure ulcers. But a lot of patients loved ones at a certain point will decide that actually that's not worth it. There's not a lot of benefit to, continuously repositioning a patient or providing wound care when we know that their prognosis is poor on the order of hours to days. Okay, so moving on to some of our next exam findings. For our head and neck exam, drooping eyelids are often noticed associated with the inability of patients to close their eyes, so they'll often get really dry eyes. It's also described that patients will have bilateral nasolabial fold droop, and so the face will appear more relaxed as a part of the dying process. It's not uncommon to have an acetone or musky smell. And one of the things that I want to put a plug for here is that often, patients will be wearing nasal cannula for comfort, and we'll get to that. But if the prongs are askew, when you're examining their head and neck, it can be a really good opportunity to see if there's skin breakdown on the bridge of the nose or behind the ears. That indicates that they are deliberately removing the nasal cannula and would be more comfortable without it versus just malposition. Next is respiratory findings that are many of the respiratory findings we see are portend a very poor prognosis, which includes mandibular movement with breathing and then altered breathing patterns, including apneic pauses, Cheyne-Stokes respirations, which is that indication of central apnea, Kussmaul respirations with deep and labored breaths, and then the death rattle of pooled oral secretions. You'll notice here that there's not really a need or an indication necessarily to listen to the patient with a stethoscope. A lot of what we can do can be observational and just assessing breathing patterns. Similarly, in our cardiovascular exam, unless there's a particular need to assess rate and rhythm, there is not always an indication to regularly listen to the heart. We do feel for we feel for peripheral pulses, and the loss of peripheral pulses, particularly a thready radial pulse, is also associated with death within days. And then again, poor distal extremity perfusion, which we touched on in the skin exam as being, cyanosis and mottled skin. All right. The next portions of the exam include our neurologic assessment, typically starting with mental status and delirium. We like to make sure that we are assessing for delirium and level of consciousness, but I wanted to make sure that I mentioned that doing a full mini mental status exam or a Glasgow Coma score is not proven to be of use in the imminently dying. So it's really a matter of just observing a patient for a short time for spontaneous limb movements, facial symmetry, and reaction to their surroundings or to stimulus. Mid-sized pupils often will strongly suggest that obtundation is due to imminence of death, as opposed to like pinpoint pupils or other size pupils that are due to pharmacologic reasons, and that can be reassuring to family members sometimes. And the one thing I didn't include on this slide, but we probably all remember from our SEP exams, is the fixed blown pupils can signify herniation of the brainstem in certain indications. And then I just wanted to mention that while we worry sometimes about myoclonus or seizure, and certainly we would want to treat those often with benzodiazepines, these are not actually predictors of imminent death. They can occur in our actively dying patients, but they don't predict any particular prognosis. And the last kind of other aspects of the examination of the patient that we're doing is looking at their urine output. A lot of the times, or decreased urine output resulting in anuria is very prognostic for imminent death. And a lot of end-stage dementia patients may develop a meconium-like stool odor, but you'll notice that there's not a lot of indication to do an abdominal exam, a full musculoskeletal, rectal, GU, any of these other more specific exams, maneuvers that could really just cause discomfort and not help us make a patient more comfortable. So after doing our full exam, and we've acknowledged that some of these findings are associated with imminent death, I just wanted to bring up these 5 exam findings, which are the strongest predictors of death. So recent studies have shown that within less than 3 days, patients who have mandibular movements during breathing, in particular Cheyne-Stokes breathing pattern, the death rattle, loss of their radial pulse, or stop producing urine are highly specific for impending death. However, it should be noted that while these are very helpful if present, they're not very sensitive findings. And so only half of patients who subsequently died in kind of the expected time course displayed any of these findings at all. So the lack of any of these 5 exam findings should not permit you to assume that patients will survive, but these can be really helpful exam findings. In particular, I read a study that noted that the death rattle is associated with death, like time from onset to death has been, there's a median of 16 hours. So that one in particular is quite predictive. All right, so I don't know if there's questions in the chat that I can't see or haven't addressed, but we're kind of switching gears. Maybe. All right. Oh, sorry guys.
Sorry, that was me to see the chat. So the question in the chat, do we know the pathophysiology of these ulcers and why does that happen? And then another question about the ulcers, are these gravity dependent?
Oh yeah, those are good questions. And I'm not going to have a particularly satisfying answer because I don't think we understand the pathophysiology except that it, represents poor perfusion to the skin as an organ system. And it seems like they are predominantly pressure dependent. They're just not what we think of as typical pressures, like pressure sores. They're occurring in areas that are experiencing pressure or like bony prominences that often can be rubbing up against something or having like particular like traction. A lot of patients who, as the bed goes from a supine position to like being more upright, you'll get like traction on the skin that can cause some breakdown, is what I've learned. Okay, so moving on from physical exam findings to kind of what do we do with this information? As I said, the goal of this is to help recognize the active dying process early so that we can start to have goals of care conversations with patients' families. And I'm not going to really go into like how to have a goals of care conversation with family members in this talk, but this is, kind of the impetus for us to start to discuss transition to comfort measures only. It was also interesting to learn as I was doing some research for this talk that in addition to talking with patients' families, identifying a patient who is imminently dying can really help us with our communication with our colleagues. And there's a strong recommendation from some of the palliative care programs that I was looking at that it is a diagnosis. Imminent death is a diagnosis that we can give to patients, and rather than using language that says patient has a poor prognosis, to actually put in the chart patient is actively dying, patient is dying, can really make sure that everybody in the care team is on the same page with next steps. So broadly thinking about comfort measures, the main goal of this is to stop treatments that are not contributing to a patient's comfort. Obviously, this is a very personalized decision, specifically with medication changes. Some patients may be on medications that aren't directly related to comfort, but for them are really important. The example I often think of is anti-epileptics in patients with a seizure disorder, as being something that could maintain their comfort in the end of life. And then, this is a good opportunity to also discontinue unnecessary IV hydration, antibiotics, finger sticks, vital signs checks that we don't need any longer, and unnecessary monitors pulse ox and cardiac monitor. And then really focus on symptomatic treatment. So providing really excellent oral and skin care for our patients can keep them comfortable, and then just treating symptoms that are arising. So we talked a little bit about how patients will get dry eyes and lips. They'll have these oral secretions that can result in the death rattle. And then there's a lot of terminal restlessness, which is delirium, fever, or excuse me, not fever, pain and pain. I'm trying to advance the slide. Maybe. There we go. This is just a diagram from a website that I liked, and it kind of explains that in addition to pain and the dying process being kind of disruptive, there's also an emotional response that patients and loved ones are having to dying that can be a big contribution to their restlessness at the end of life. And patients will sometimes have nonsensical conversations, talking to people who are not there, describing things that others aren't seeing, followed by periods of lucidity, and that just acknowledging that this can be really distressing for loved ones who are at the bedside, if they're at the bedside. Okay. So in treating patients symptomatically, one might ask, how do we know if patients are symptomatically dyspneic, if they can't communicate with us, if they are actively dying, which is a very valid question. So on the screen here is an example of a respiratory distress observation scale, which is a validated tool that can be used to help identify when patients who are having abnormal breathing patterns that we observe are actually in distress and would benefit from symptomatic like PRN intervention when they can't report for themselves. And this is just one example. It very broadly includes manually checking the respiratory rate for a full minute, assessment of a patient's restlessness, their accessory muscle use, whether they're grunting at end expiration, nasal flaring. And the big one is really just a generalized look of fear that's described on the slide there, with eyes open, brow furrowed, teeth together. And I just circled in orange there the scores that we use for that this particular observation scale uses for deciding whether a patient would benefit from symptoms. And you'll notice it's not much. We have a low threshold to leaning towards symptomatic treatment of these patients, understandably so. Really anybody who looks like they are fearful and breathing irregularly is going to qualify for symptomatic treatment. And so in that vein, we can talk a little bit about managing dyspnea at the end of life. There are a lot of bedside techniques that aren't pharmacologic that we can try, which include increasing air movement past the patient's face with a fan or an open window, discontinuing IV fluids that could be contributing to dyspnea. A therapeutic trial of oxygen is often helpful, but really we should base continuing this on symptomatic improvement and not on anything like oxygen saturation. There actually was a randomized controlled trial that showed that there was no benefit to oxygen over ambient air when both were delivered by nasal cannula in patients who are not hypoxemic. So it really is about, more than anything, it seems to be about air movement and past the face. And then, our mainstay of treatment for the sense of air hunger is opioids, morphine in particular. One thing I wanted to touch on is that sometimes families will have a fear that opioids can be sedating and can have respiratory suppression effects. And there's concern that maybe this can represent, hastening death, either euthanasia or assisted suicide. And so if you're asked those questions, I can tell you that there is no evidence that, properly managing symptoms of terminal dyspnea with opioids hastens death in any way. So we can provide symptomatic relief without worrying that we're, hastening a patient's death. And then, of course, always important to make sure that we're not missing other concomitant symptoms. For example, cough, or in particular, anxiety often co-occurs with dyspnea and air hunger. Okay, and then talking about secretions, the last symptom I wanted to touch on was the death rattle, which is very distressing to hear for loved ones. But we have pretty good evidence that This phenomenon is not uncomfortable for patients who are actively dying, which, makes sense. They are in the very last stages of their life. They're often not particularly alert. And really the distress is coming from the loved ones who's at the bedside and watching somebody they care about appear to be suffering. And so the first stage in treatment of the death rattle is to just communicate with family members, be open about, what are their fears, how are they interpreting these symptoms, and then help reframe what we're seeing to help explain our thought process of what we expect as providers, the progression of the dying process to look like, so that everybody can expect the same things and be on the same page. And so it's not uncommon to treat the death rattle, again, more for the observer's comfort level than anything else, but that's not an unreasonable reason to treat somebody at the end of life. And so some things that are plus minus helpful is adjusting patient position, putting them on their side or in a semi-prone position to try and mobilize secretions. Gentle suction is okay to try, but again, these secretions usually are pooling fairly distal and not really amenable to suction. And so our mainstay of treatment is anticholinergics, antimuscarinics. Although I just will say that everything is a risk-benefit analysis. And so these medications often can cause increasing delirium and confusion and sedation, which is why I think starting with that communication with family members about kind of what would be their and their loved ones' priority. Would it be to be a little bit more alert, even though their breathing pattern is more concerning, or would it be to make breathing as comfortable as possible? And then the last little topic that I wanted to address is common questions that we often hear from family members. I'm not going to answer all of these, but I just wanted to acknowledge that the information we've talked about can hopefully be really helpful in being ready to answer these questions for loved ones. And I bring this up because, again, early recognition of the dying process can help us to start having these conversations early. And be prepared for these questions so that we can have an answer when family members ask us. And I just wanted to put in a plug here for recognizing anticipatory grief on behalf of loved ones, especially if patients tend to be on the longer end of that 2-week time frame and or have been sick with dementia or cancer or some other chronic illness for a long time, because loved ones have often been grieving their passing even in advance of their death. So that can just be something we can be aware of. And then I think probably the trickiest question that many people maybe dread is this one, which is about nutrition support at the very end of life. Again, not focusing on patients with reversible causes, but at the very end of life. So I just wanted to touch on this topic and provide maybe some information and skills that could help people. I think I just want to come from a place that it is really understandable that family members are concerned about their loved one's nutritional status at the end of life. Even though, we are able to recognize that patients are actively dying, it's a very common question that I have experienced, that loved ones want to know if feeding tubes would be helpful. And I think it's important to recognize that this comes from a place of really great love for their loved one. And reasons that I've heard from family members is that, they just want to be as active as possible in making their loved one comfortable and maybe prolonging their life so that people can visit or they can get home or whatnot. I've also heard from loved ones that, providing food and feeding one another is an expression, is how they express their love. And so not being able to do that is really distressing. And so, it's hard for us sometimes to have this conversation because we're trying to sometimes push evidence on patients when in fact they're coming from a very emotional place. So I just wanted to give you some of these bullet points that can hopefully be helpful. First of which is that there's no evidence that feeding tube placement prolongs life for an actively dying patient dying from either advanced dementia or another chronic illness. Or protects against aspiration pneumonia. And actually, from our standpoint, we worry about aspiration pneumonia with an NG tube placement. Most Actively dying patients do not experience hunger or thirst. The reason for their decreased PO intake is often due to ability, but also often due to just lack of interest in eating as their body shuts down. It is common that patients have a dry mouth, but that's not proven to be related to their hydration status. And so we can treat that with other like more localized symptomatic moisturizers in other ways rather than placing a tube feed. And then there is not any good evidence that providing enteral nutrition will improve the patient's quality of life. And I like to explain to my patients that really I worry that placing an NG tube is not going to make them more comfortable. It might make them less comfortable because it's very delerogenic, that it's uncomfortable, and it's something that they could potentially pull if they are distressed. So hopefully that you guys find that helpful as well. And so I just wanted to wrap up with a couple of take-home points. First being that dying is a multifaceted process. It's unique to every patient, but there is a stereotyped trajectory that can be recognized and signals impending death that we should be aware of in our critically ill patients. The exam findings that portend the most imminent death include vital sign derangements, the mandibular movement with breathing, abnormal breathing patterns, the death rattle, decreased urine output, and loss of extremity pulses. And last but not least, with prompt recognition, we can help patients to have a good death, whatever that means for them and their family members. And sometimes we can get them home. And we can also provide support and comfort to loved ones throughout the dying process if we are aware that a patient is in fact dying. So that was my slide. I wanted to give a shout out to Dr. Margaret Isaac from Adult Medicine Clinic, who introduced me to this topic when I was first exploring it. But that's all I've got. And I can't see chat or people, so. Oh, there we are.
I brought the people back. Yeah, lots of thank yous in the chat. If there's any questions for Jennifer, we have a couple minutes if people have anything. Okay, well, maybe we will enjoy a little bit of an early break. Why don't we take 10 minutes and come back just a couple minutes before 9:50 for our next talk, and we'll see you all in a few.